So this is a topic that I'm very, very passionate about. I did my PhD on this topic. I'm a dietitian by profession, so we're very interested in malnutrition, and particularly malnutrition in elderly patients, but there aren't that many dietitians, and I think nurses across the board have an incredibly important role. So when I was invited to talk at this conference, being that your practice nurses, I thought fantastic. You're probably, well, I know you're incredibly busy, but you are probably the first line or first point of contact for many of these malnourished patients in the community, because as I'll go on to show, this is where most of those patients are. So how can primary healthcare nurses aid in identifying nutritional risk in patients? So I'll go through this, but if anyone has any questions during this, please interrupt me and shout out. First of all, I'm going to go through disease-related malnutrition, which I'm sure you've all, definitely you will have seen. You may have even covered some of this in training, either at university or since you've graduated. I'll talk about the important role of primary healthcare in managing malnutrition in these patients, how you look for it, because it often goes unidentified. So the UK are getting pretty good at this, and the Scots are actually the best in that they've made it mandatory for any patient that gets admitted to a hospital to be screened for malnutrition within 72 hours of admission. And the Princess Alexandra Hospital, where I do a lot of my research, they've recently become the first online hospital in the country. So as part of the clerking on the ward, malnutrition screening is done. So the first thing that happened was there was just a huge amount of referrals to the dietetic department, and there wasn't enough dietitians to see all of those referrals. So as IEMR comes in, a lot of these patients are going to get picked up. So then there'll be lots of people saying, okay, what do we do with them? How do we help support them? And I'll talk about some first line interventions as well. So it is a very emotive topic. It's something that most family members are very finely attuned to, particularly in hospital. The media do pick it up, and they do report it in quite a sensationalized way, because as you can imagine, when people are sick and they've got chronic disease and they're acutely unwell, they do tend to become malnourished, and if they get admitted to hospital, they often lose more weight during their hospital admission. That's just the nature of being hospitalized. So we know the majority of patients will leave hospital weighing less than they did on admission. The media obviously pick this up and say, well, they're not being looked after in hospital, when in fact they're just really, really sick. What needs to happen is when they get discharged back into the community, that is when they need to get support with their nutrition. So any losses that have occurred during that hospitalisation, they can then recoup those losses back in the community setting, and they're less likely to be sick. So if you do give them any nutritional support, they are probably more likely to respond to it. How we help people age healthily, and how we keep them out of hospital, and most importantly, how we ensure that they have a good quality of life, is becoming increasingly important. And as we have a multi-morbid aging population and the burden it places on hospitals, and governments are picking this up, and the UK government are probably a little bit further ahead with this than the Australian government at the moment. So there's lots of cost analysis on the burden of malnutrition and the potential cost savings for good nutritional support. And I'll present some of that later. Age UK have produced a number of reports now around still hungry to be heard, and there was, just at the start of this year, there was an all-party parliamentary group on hidden hunger and malnutrition in the elderly. So the government are recognising that as the population ages, ensuring that they don't lose lots of weight and become malnourished is really, really important. This isn't new. So Hippocrates highlighted this a long time ago, who highlighted that a slender diet is always dangerous in chronic diseases, and also in acute diseases where it's not required. So my background is in respiratory disease, and in particular COPD patients, and they peeing in and out of hospital pretty much all of the time, and it is those malnourished ones that do that more frequently. And Florence Nightingale as well, in her Notes of Nursing, came up with a very famous statement, which I'm sure you've all heard of, saying every careful observer of the sick will agree in that thousands of patients are annually starved in the midst of plenty for want of attention to the ways in which alone make it possible for them to take food. So as part of that would be also identifying these patients as at risk, because they often go unnoticed, and you will occasionally hear, and even patients themselves saying, I'm just getting a bit older, this is just how it is, and that's not necessarily the case, particularly when they start to lose lean body, so fat-free mass, because that's the strongest predictor of whether they're going to survive. It's the strongest predictor whether they're going to get admitted to hospital, how long they stay in, and also their quality of life as well, which is something I'm really interested in. So rather than just giving them nutrition to get them to gain weight, so what are those functional improvements that are meaningful to the person? There's a number of problems with aging, as you're aware. So the etiology of malnutrition is really, really complex, and you could probably, if I asked you, you could list a dozen things. So sight, changes in even smell, taste, dentition, functional capacity, budget constraints, isolation, deprivation, food literacy. I mean, you could make a list. We could spend half an hour just talking about the potential causes to malnutrition in this patient group. So it's very, very complicated, and it's very, very common. One of the issues we have is that older people do get ill. They've often got chronic diseases. So in the COPD patient group that I'm particularly interested in, their condition is punctuated with these acute exacerbations of the disease that then cause them to get admitted to hospital. Their nutritional intake is compromised, they lose weight, and what we know about elderly patients is that their ability, even when they're better, so even once their post-acute episode is over and they're back into the community, their ability to recoup that weight that's lost is impaired compared to just healthy individuals. So this study here, which is very, very well known in the nutrition field, these are 35 healthy younger males versus 35 healthy older males. So there's no underlying disease here. They were underfed. This data is so strong that no ethics committee would approve anyone underfeeding older patients now, because it's very clear that they don't develop that hyperphagia, so the drive to eat, that younger patients or younger individuals will have. So even on refeeding, they just never gained the weight that they lost. So you'll often see these patients coming in, they'll get sick into hospital, they'll lose weight, they'll get discharged back into the community, they'll plateau out again. Hopefully at that point somebody will pick them up, or the dietitian will refer them to community. They'll get sick again and they'll drop down again. So it's this slow decline in body weight and functional capacity. I'm sure you've had talks about frailty at some point. It is, I know now, any nutrition conference we go to, there's a move from malnutrition to frailty. So I'm going to a conference in September, and most of that conference will be on frailty, malnutrition and aging. So we know that they cluster together. So this is a study in 1,200 elderly individuals in the community over the age of 65. They were actually screened for malnutrition using the APNA tool, which I'll come on to later. And they found a third of them were identified as being frail, and 30% of them were also identified as having pre-frailty. So, importantly, those patients that were identified as malnourished were 3 times more likely to be frail. So that could impact on their quality of life, their functional capacity, their risk of experiencing a fall at home, even their ability to acquire, prepare and consume food. So often a lot of the patients that I looked after in the UK, they would struggle to get to the kitchen to prepare a meal, and even if they did, by the time they got back to their lounge, they were just so fatigued, they were almost just too tired to consume it. So a huge amount of effort expended in a frail individual just to prepare their food. So we'll come on to some quick and easy tips that can help these individuals. So BAPN in the UK, which is the British Association of Parenteral and Enteral Nutrition, there's a link there to some good resources. They have done a lot of work over the years in this space, and in fact they've got one of the largest nutritional screening week cohort datas in the world. They've done it over 4 years now. And what they've reported in their numerous reports is that malnutrition is very, very common, it's very, very costly. 50% of the costs are attributed to the over 65s. So you can imagine as that population gets older, the costs are going to rise pretty much exponentially. And that presents a problem to all healthcare systems, particularly the National Health Service in the UK, which is publicly funded, because the pot of money will eventually run out unless the Brits like getting taxed more, which we don't. So I've mentioned they're unable to shop for themselves, they've got mobility problems, they've also got this background of chronic conditions that they may have been living with. An area that I've started to do research in and published just this year is around poverty and social deprivation. So in the COPD patients in the community, the strongest predictor of whether they would get admitted to hospital or if they had malnutrition and their healthcare costs was their postcode. So it's a big societal issue as well. The issues around being socially isolated and depression are also really important, because we know that older patients tend to consume more food if they're in a social environment, which is why having dining rooms at the end of wards and having dining experiences in residential aged care facilities are really, really important, particularly individuals that have cognitive impairment. And swallowing difficulties and aspiration, you will all have come across the challenge of that, and that could almost be a separate talk on itself because it's extremely challenging. So the problem we have in healthcare is that we've got this malnutrition carousel. So 40% of the patients walk through the door already malnourished, but they've also got this background of an acute illness. And what we know is that the malnourished patients that come into the hospital, they stay longer, they have more complications, they're more likely to develop pressure injuries, they require more medication, the healthcare costs are a lot higher, they need more support post-discharge. When they are in the community, they have more GP visits, which is why community practice nurses have an incredibly, they're in an amazing place to look after these patients. They have more dependency. ONS is oral nutritional supplements, so they tend to require a higher prescription of oral nutritional supplements, which can be costly to healthcare systems, although when we've done the cost analysis, the return on that investment, which I'll show you later, is more than recouped. And the big problem that is getting on the agenda of most hospitals is the early readmission rate. So as the patient gets admitted to hospital, the hospital get a lump sum for that admission. If they get readmitted within 30 days, it's often halved, or at least reduced by a third if they were readmitted within 30 days. So keeping malnourished patients out of hospital beyond that period is really, really important. And as I mentioned earlier, like 70% are way less on discharge. So malnutrition in the UK, it's been really well defined. At any one time, it affects 3 million individuals. So there's about 150,000 NHS hospital beds. So you can see the problem we've got at the moment is that most malnourished patients are not in the hospital, and as dietitians in the hospital, we're very good at identifying, but there's not much we can do in that setting. It currently costs the UK 20, or this is just, on the left is just NHS England data, so not even the UK, this is just England. So it currently costs the National Health Service in England £20 billion per year to manage disease-related malnutrition. And the National Institute for Health and Clinical Excellence, they've done an economic analysis, and what they found was that if they rolled out their clinical guideline, predominantly in the community, it could save them £200 million per year. On the right is US data, and Australian data is very similar, so it hasn't been analysed in as much depth, but the costs are the same. And you can see on the US, up to one out of 2 older adults is at risk of malnutrition. It's a huge challenge, and it's not something that any one healthcare professional can treat effectively. The thing that I'm interested in, and most healthcare systems are interested in, particularly when it looks at whether nutritional support is effective, is around cost. So how much does it cost to give the nutrition in the first place? How much cost does it save you? And then also quality of life. Can you improve the quality of life of these malnourished patients? I'll come to that in a moment. This is data we presented at a conference last year. It's from the PA hospital, where we just followed up a cohort of over 800 COPD patients that came through outpatients. Nearly 300 of them got admitted to hospital. The malnourished ones, as I said, stayed longer in hospital. They were more likely to be readmitted. Their survival was significantly poorer, and they were more likely to be readmitted as well. So the cost was almost double for the malnourished patients. And we've now gone back and looked at that data to see how much time the dietitian would have on the ward, and over 50% of the patients were there for less than a week. So, and I think dietitians are very, very useful, but in that setting, there's not much we can do in an acutely exacerbating malnourished COPD patient. We have to just identify them and then coordinate care into the community. This is what kind of freaks me out, because at some point I'll be old and probably malnourished as well, and hopefully there'll be a healthcare system there to look after me. But this is data that came out late last year from the UK, where the health economists have got hold of the data, and they've looked at the changes in population over the coming years and different levels of healthcare inflation. And by the year 2042, with high healthcare inflation, it's estimated that malnutrition could cost the NHS nearly £90 billion per year. So I think that's 25% of the healthcare budget. So that's quite frightening. And Queensland is going to encounter the same thing. So it's just really just acute. Nurses that work in the hospital setting will tell you this. It's just they're not building more hospitals. The population is increasing. It's getting older and sicker. So if you've got less hospitals and a larger demand, the only thing you can do is drive turnover. And that's reflected in this graph here, which is the length of stay over the last few years. So in the UK, it's dropped down, but in Australia, the average length of acute stay in 2015 was 4.7 days. Now, I say to my dietetic colleagues that work in the hospital is, we're pretty good, but you can't really do anything in less than 5 days in a malnourished patient. Impossible. So it requires us to coordinate care back into the community. And I assume it can't go any lower than less than a week, but I'm sure that there'll come a time where there's an increase in just day cases, where only the sickest get admitted to the ward, which is why I'm really passionate about the work that clinicians do in the community. So whether that be dietitians, the carer workforce in Australia and in the UK, Europe and America, completely underutilised for managing patients. But I do think practice nurses have an incredibly important role, particularly if you've got concentrated periods of time in the year. So something that we were going to do in Southampton in the UK before I decided to move to usually warmer climates than the south coast of England was to look at the prevalence of malnutrition in the COPD patients in the community when they come in for their flu vaccination, because we know that's a time where they're all going to come through within a couple of weeks to get their flu jab. We were going to get them to just screen themselves using a screening tool that we use in the UK as a way of just them identifying themselves as at risk of malnutrition, going in to see the GP, and then them having a quick referral mechanism to community dietetics, or that the practice nurse could hand out first line advice. So the problem we have at the moment with our kind of nutrition and dietetic workforce, and it's not necessarily a problem because it is good to have lots of dietitians in the hospital. Usually about 70% of our workforce is in the hospital. We know that that's kind of a funnel, a great opportunity for dietitians to identify patients at risk of malnutrition and do a formal nutritional assessment and formally diagnose them with malnutrition. Start treatment, but it is what happens in the community setting is where we really need to leverage our clinical expertise. So in Queensland, there's only 395 dietitians. So there's only so much we can do. And the vast majority of Queensland dietitians do work in the hospital setting as well. So there's not enough dietitians to see all malnourished patients, and there never will be, according to the Chief Allied Health Officer. They're not going to double our workforce as the population doubles. And also the majority of malnutrition exists in the community as well. So do you push dietitians into the community? I don't think that's effective either, because it just means the workforce is fragmented. I think it's more important to have them in an area where we know malnourished patients are going to go through at some point. This slide just emphasised the challenge that we've got. So on the left-hand side is a chart indicating the distribution of malnutrition at any given time point. So not in the hospital, mainly in care, well, mainly in the community. There's some in sheltered accommodation, and there's lots in care homes as well. But the cost is primarily, the cost associated with malnutrition is primarily driven by that hospitalisation rate. So, yep, malnourished patients get admitted to hospital more frequently, they cost more money. That's not the best place to treat them. It's actually in the community when they're less unwell. So, there are lots of tools out there. Has anyone used I think the APNA is quite commonly used in the community. Yep, so some people have. Any other tools being used? The malnutrition screening tool is very, very common for anyone that's based in Queensland. It's a very quick screening tool as well. The good thing about the APNA form is that it's both a screening tool and an assessment tool. So there are some information packs at the front with the tool, and there's recommendations for intervention as well. And I think Nestle are doing quite a lot of work in this space in helping trained practice nurses to get confident in using it and linking it to first-line nutritional intervention strategies. So there is no point in looking for malnutrition if you're not going to treat it, and there's it's almost unethical to screen someone as malnourished or at risk of malnutrition and then not initiate some form of care. It'd be a bit like diagnosing a chest infection and not prescribing antibiotics. So if you are going to look for it, it does need to be linked to a nutritional care protocol, and there are lots out there. When the APNA first came out, it did include 18 questions, so it's very, very well validated. It's been stripped back to 6, and again, it's been checked, and it is still very valid. So it's only 6 questions, very, very quick to do. Ask questions. Part A is, has your food intake declined over the last 3 months due to a loss of appetite, digestive problems, chewing or swallowing difficulties? And you score the patient for that. You ask them if they've lost weight recently, and a lot of elderly patients will say that they have, and it's very seasonal as well. If they've picked up a chest infection or they've had a bit of flu, they will lose weight. The challenge we've got now is that, and this is where I think experienced practitioners such as nurses, is that the APNA or any screening tool is just a tool. It's only as useful as the person's hand that you put it in. So my brother's a carpenter. If I had access to all of his amazing carpentry tools, you still wouldn't want me to fit in your kitchen for you. I would do a terrible job. And the same is with a screening tool. If you just give it to anybody, it might not necessarily work. It's someone that knows what to look for alongside the tool. So wedding bands that are loose, belts that have changed, clothes that look like they may have fitted once but now they don't, dentures that are ill-fitting. All of these types of things that experienced clinicians will be able to pick up, and the tool is just a really useful way to kind of frame your clinical judgment that you'll have developed over years of experience. Mobility is a big one, so are they bed-bound or chair-bound? That if they are at risk of malnutrition, that's really, really important, because their risk of then developing pressure injuries is increased. Have they suffered psychological stress or acute disease in the last 3 months? Particularly males, if they've lost their partner, we tend not to survive or do very well on our own in the wild if we lose our partner. I'm hoping that will change, because hopefully guys have learned how to. Well, now we can just Uber Eat, so we'll just Uber Eat, so we'll be okay now. But years ago, we wouldn't have known how to open a tin. Hopefully that will change. Dementia is an issue as well. So we know that even with mild dementia, mild cognitive impairment, people's intake does start to decline. And one that we're doing lots of research locally at Prince Charles, PA, Royal Brisbane, and through QUT and UQ is around body mass index. So you'll see the APNA, they start to score with a BMI of less than 23. We've got a paper at the moment published from, under review at the moment from Prince Charles, where we included I think it was over 3,000 patients from the Queensland bedside audit, and we found that a BMI of less than 26 in the over 65s was when you started to have a stronger association with malnutrition. And this is a real headache now for people that have screening tools and dietitians, is that we've got this population that's getting older, they're multi-morbid, but then they're also getting bigger. So how the utility of BMI at picking people up as at risk of malnutrition, we're saying that maybe some of these tools need to increase their cutoff for BMI to identify malnutrition risk. So BMI less than 23 in over 65s, definitely that they would start to score. Have in the back of your mind that if they've got a BMI of 29, but they've got loose-fitting clothes, the wedding band, and all those types of things that could predispose them at being at risk are also important. And also they include calf circumference. So in those packs, there's a calf circumference measurer. That's a particularly useful way of diagnosing malnutrition, and also it would be associated with frailty as well. So at the bottom, you can diagnose whether the patient has a normal nutritional status, in which case, and I'll come onto this slide next, that they've produced this guideline in the UK, and there does need to be something similar tailored for the Australian setting, and it will align to something like the APNA here, where it's got a traffic light system. So if you diagnose your patient as a normal nutritional status, in the UK, what the Malnutrition Pathway Group have done is that they've got a leaflet that is available for the patients to pick up, just around healthy eating or eating for healthy aging. So it's nothing about malnutrition, it's just how the importance of protein as we age, for example. So that's been formalised. This is freely available on the UK, on this website. I think Australia needs something similar. So this was endorsed by a number of professional groups. So the British Dietetic Association were involved, the Royal College of Nursing were involved, the NNNG, which is the National Nutrition Nurses Group in the UK, they were also involved. So they've produced this comprehensive guideline that they're now rolling out in the UK community, so a guide to managing adult malnutrition. If they use a different screening tool over there, but exactly the same principle. If someone is normally nourished, they get given a green leaflet. If they're at risk of malnutrition, they get handed this yellow leaflet or amber leaflet, and it just talks about the importance of consuming lots of small, frequent meals. It recognises that as we age, our appetites are poorer, so maximising every mouthful. It starts to introduce food fortification strategies, so that's our first line treatment, is to fortify the foods that the patients are eating so they can maximise every mouthful of food, making sure that they're having high biologically available protein, for example, so meat, fish, eggs, dairy. So they all contain good sources of protein. Not only that, they contain really good sources, good profiles of amino acids, which we know help patients maintain their lean body mass. And if they are doing any sort of exercise, even walking, it will help them increase their lean body mass as well. If they score red, they then get handed a red leaflet and a referral to a dietitian. So again, if they're at risk of malnutrition, doctors, nurses, carers, family members can do frontline intervention around food fortification. If the patient is diagnosed with malnutrition, or they're likely to become severely malnourished, so if it's clear they've lost a large amount of weight and they're not doing very well, a red leaflet and a referral to the dietitian. And this is where we start to look at prescribable oral nutritional supplements, which are usually ready, you'll know this. So they're usually ready-made liquid oral nutritional supplements that are ready to drink, or they can be in a powdered form. At the moment, the vast majority of the evidence for nutritional support in the treatment of malnutrition in the community is primarily based on the ready-made liquid oral nutritional supplements. But there has been increased interest, and I'll talk about one of the studies we've recently finished in the powdered supplements. So Sustagen is the example that we use locally here. So in Metro South, we use Sustagen in the community. But there are other strategies. So this is a really good example by Liz Weeks, who's a consultant dietitian at King's College London. She did this as part of her PhD, where she got a group of malnourished COPD patients, and she gave them an education leaflet, and she gave them a 6-month supply of skim milk powder, or whole milk powder I should say. So relatively cheap product. And she saw them at the start, at 3 months and at 6 months. So she reinforced the education that she gave them around the need to consume frequent, high energy dense, rich protein foods, lifting any sort of restrictions that these patients have, because it's another barrier that we have, is that they've got, they might have diabetes or cardiovascular disease, dyslipidemia, and it's highlighting to them is that at that moment in time, those conditions may need to be managed primarily by the medical team, and any restrictions that they were having need to be relaxed a little bit, because the treatment of malnutrition takes priority. Otherwise, they're more likely to get an opportunistic infection and potentially not do very well. So what Liz found was, so the control group just got given a leaflet. So this is quite interesting, I thought, is that they got given the same leaflet, but that was it. You're malnourished, here's a leaflet, good luck. And in the leaflet it did recommend that the patients go and purchase the milk powder that the other group were provided. So what she found was that the control group didn't purchase the milk powder, and you can see they, at the end of 12 months, they'd lost about 3 kilos in their body weight, 3 kilos of body weight. Now in a malnourished COPD patient group, that's not good, it's almost a disaster. And then going back to that earlier slide which I showed around healthy elderly patients and their ability to recoup any weight they've lost, it would be even worse in patients that have a chronic disease like COPD. But amazingly, the group that were given the tailored dietary advice and the milk powder, they significantly increased their weight at 3 months, and at the end of 6 months the intervention finished. So she didn't provide them any more advice at 6 months, but because we can only assume that because the advice was tailored to the individual, they continued to manage their nutritional status. So their milk powder supply was actually cut off at 6 months as well, but because the advice was tailored to the individual and the recommendation to purchase the milk powder was also tailored, those patients were more likely to then go and purchase the milk powder themselves. So a 2 kilogram gain in weight in a malnourished patient group with COPD is amazing. It's the threshold of weight gain that you start to see functional improvements. So hand grip, 6-minute walking distance we use all the time, and also the St. George's Respiratory Questionnaire. There's a huge difference between the two groups, and it was maintained up to a year, which is incredible. That's just mid-arm muscle circumference change, so it's just a surrogate measure for lean body mass. So you can see that the group that lost weight, they didn't just lose fat mass as you'd expect, they'd lose a bit of fat and a bit of muscle. The weight that was gained in the intervention group was primarily fat gain rather than muscle, which can be expected unless you give the intervention alongside like a rehab program where they're doing some form of exercise. And most importantly, their quality of life. So a drop in the SGR, I mean, some of you probably work with COPD patients, so apologies because this is preaching, you know all this stuff already. A drop in SGRQ score of 4 or more is the minimally important clinical difference. So at 6 months, the patient's quality of life significantly improved, and enough that they'd noticed themselves. And then at 12 months, it was just hugely improved. So not only are we getting these patients to just gain weight, which is great because it means they're less likely to be admitted to hospital, but also their quality of life improved so much that they would notice themselves, which I think is why I got interested in nutrition and dietetics in the first place. We've got, and so that was in milk powder. We recently did a study that finished a couple of months ago in Metro South in the chronic care disease team. So Val Conway, the dietitian there, ran this study where we recruited malnourished COPD patients and we randomized them to one of two groups. So one group received individualized dietary advice by the dietitian and an educational leaflet. And as part of that recommendation in routine care was go and purchase Sustagen. And then the other group did exactly the same, but we gave them a supply of Sustagen for 12 weeks. The reason why we did that is we wanted to see, do patients actually go and buy the Sustagen? We know that they're quite a health literacy and deprivation and budget constraints in COPD patients in the community are rife. It was a very difficult study to recruit to because we could only recruit if they were 4 weeks post-exacerbation. So trying to recruit malnourished COPD patients that are 4 weeks post-exacerbation is like, I don't know why we did it, but they'd get to about 3 weeks and then have another exacerbation. So we managed to recruit just under 40 patients over 18 months, and we were guns blazing to get that number. So we didn't find any difference between the groups at baseline or at week 12, but when we combined the groups together and just looked at did nutritional support have an impact, it did. So the patients gained a significant amount of weight, about 1.9 kilos, so just under Liz Weeks' 2 kilo threshold where we see quality of life improvements. Their quality of life was significantly improved, so their SGA score dropped by about 5.5, so over the 4 threshold. We did find that in the group that were not provided the Sustagen, their consumption was about 48% at week 12. And the group that were given the Sustagen was 60%. So it was almost significant. So if we gave the Sustagen to them for free, they would be more likely to take it, and their intake tended to be higher, and they were more likely to gain weight at 12 weeks than the group that were just routine care. So that's raised a number of questions for us. One around frequency of support. So seeing them at just baseline week 6 and week 12 wasn't enough to keep the compliance high enough. And what we also found was that the individualised dietary advice did work alongside providing them with a powdered supplement. So that's quite an important study in that it's the first study in malnourished COPD patients that actually used a powdered supplement versus a ready-made supplement. So that's going to be presented in September in Madrid at the International Nutrition Conference. So I would just like to finish off before I have a discussion about this and answer any questions you've got. So this is a big report, and there is a shortened version available online for anyone that wants to read it. The big one is huge. It's an economic analysis done by the NIHR in the UK alongside BAPN, which is the British Association of Parenteral and Enteral Nutrition, in collaboration with NICE. So they looked at the cost effectiveness. So we know malnutrition is a problem, but if we implement routine nutritional screening, mainly in the community, and the nutritional support that would then flow on from that, what would be the impact of doing that? So the big thing was that they had to cost out the cost of getting nurses in general practice to screen patients and the cost associated with that and taking up their time. So you can see here that there's a significant amount of cost in the screening there, and they use a whole different bunch of economic modelling that I don't understand, but they decided to pick one in the end, and they justified which one. So you can see here, screening is the primary cost. Then you've got assessment, so that's when the dietitian comes in. So the malnourished patients come through, they get sifted through, and then the dietitian would do a formal nutritional assessment. So that's it, usually using the subjective global assessment, where we'll look at fat-free mass depletion, take a much more detailed dietary history. There is a subsequent increase in the number of prescriptions of oral nutritional supplements. So in the UK, it's just given free, they're freely prescribed. There's also an increase in the number of enteral feeding and parenteral nutrition as well. So it's not just oral nutritional supplements. If you start looking for malnutrition, you're more likely to start to identify these people that may have an underlying cancer, or they've had they've developed dysphagia over the last 6 months because they've got mild cognitive impairment, and then that leads to them requiring maybe a PEG in the community. So there is an increase in all forms of nutritional support, but the net cost saving overall is about £65.5 million, which is, when the National Health Service look at things, they look at it in terms of like cost per quality, so ROI pretty much, what's their return on investment. That's, I think it came out as the second or third most cost-effective treatment available to the National Health Service is nutrition support, which makes complete sense to me as a dietitian. But I just thought that was fantastic. But the big thing that they're highlighting to government over there is that this doesn't come without a cost. If we're asking practice nurses to screen in the community, there is a cost associated with it, but that cost is more than offset by these patients not getting admitted to hospital, which I think is the whole purpose of healthcare. If you were to extrapolate those numbers to Australia, that would result in a net cost saving to the healthcare system of 53.5 million, which is pretty much the wage bill for the entire dietetic workforce in Queensland, which is not bad. You can almost use that money, reinvest that money in other ways, I think. So hopefully that was interesting. It's a bit of a whistle-stop tour through malnutrition, the problems, how you identify it, but hopefully you didn't need convincing that it was an important thing to look for. But if you are looking for this in your practice, using a validated screening tool is the best thing you can do, linked to a nutrition protocol, and you might not see changes straight away, but be rest assured, on a population level, if we start nutritionally managing these older patients in the community, it will not only improve their quality of life, but also reduce their healthcare use. Thanks.